Okay, thanks very much to the organising committee for inviting me to talk. I'm going to talk about bronchiectasis and give you an update over 10 minutes, but it should be fairly straightforward because it's much simpler than renal medicine. But I'm going to just cover some brief clinical topics that hopefully will be let's go. So I'll just briefly cover the burden of disease in New Zealand and then briefly on some investigations that will be relevant to you and some update on treatment. So this slide just notes that the hospitalisations and bronchiectasis is a significant burden in New Zealand. This is hospital admissions from 2008 to 2013 with a mean annual rate of 26 per 100,000. But you can see that there's it's a bimodal distribution with a peak in the young kiddies and a much larger peak in the older age group. And you can see that there's a disproportionate increase in admissions in the Pacific and Maori population. So the rates here are 9.1-fold higher for the Pacific group and 4.9-fold higher for Maori population. And there's a significant cost to the system from admissions to hospital, costing about $5 million back in 2013. So this is just making the point that although bronchiectasis is associated with bacterial infection, viruses are very important here, and they're commonly a cause of the exacerbation, just like they are in asthma and COPD. So I've got to bear in mind that viruses are important, and this is a study published in Chest in 2015, looking at a cohort over a 12-month period where they looked at the exacerbations during the stable and exacerbation phases. So this is sputum culture, this is nasopharyngeal swab, and this is a combination of both. And what they found was that 49% had a positive virus culture, and the most common were the coronavirus, rhinovirus, influenza, and RSV. So we're seeing a lot of rhinovirus and influenza. RSV is becoming more important in the elderly population. They also found that in the stable phase you can get positive results. So that might mean that there's delayed clearance of the virus, and so that may be another factor in exacerbations. This slide just is emphasising the point that Pseudomonas is a significant problem in bronchiectasis. So previously it was thought to be a coloniser. We're now thinking of it in terms of a chronic infection. So if you were to biopsy people with Pseudomonas, they'll have inflammation going on. It's not an innocent bystander. It's causing trouble. So if you pick it up, it's an important marker of poor prognosis. So here's the FRIENDS cohort recently presented at the European Respiratory Society of 8 European countries with a large number of patients followed up with 5 years. And just about any endpoint you want to look at, they have worse outcomes. So worse radiology, symptoms worse, quality of life is impaired, they have more exacerbations, more hospital admissions, and they have higher mortality. So Pseudomonas aeruginosa cultured in sputum is a very important marker of poor prognosis. And this has been confirmed by a meta-analysis recently published as well. So what tests should you do if you get a new patient with bronchiectasis? So high-resolution CT scan is currently the gold standard for diagnosing bronchiectasis. So a chest X-ray may give you a clue in moderate and severe disease, but in mild disease you're not going to pick that up. So you want to look at the patients who are producing sputum, have a chronic cough, and doing that on a regular basis, and that will give you a clue as to whether you should do a CT scan. Once you've diagnosed the bronchiectasis, what tests should you do? This is the minimum bundle that's recommended by the European Respiratory Society, and this is looking at finding those people who have a cause that might be relevant for bronchiectasis. So a blood count looking at lymphopenia, neutropenia, maybe they've got an immune deficiency. You want to do their serum immunoglobulins, again looking at immunoglobulin deficiency. Allergic bronchopulmonary aspergillosis, they would have a diagnosis of asthma. But these are the serological tests that you would ask for. So you would ask for a total IgE level and specific IgE for Aspergillus, specific IgE for Aspergillus and IgG. So the IgE is the old RAS test, and the IgG is the precipitans. You'd ask for both of those, but it's predominantly the total IgE and the specific IgE that will make the diagnosis of ABPA. if you've got a new patient with bronchiectasis, at baseline, I think it's very important to do a sputum culture routinely, but also 3 sputa for mycobacterial cultures. This is because mycobacterial culture can develop in patients with bronchiectasis, but is also a cause of bronchiectasis. And I like to do cultures for mycobacteria on about an annual basis, just to check that they haven't acquired a non-tuberculous mycobacterial infection as well. I think baseline pulmonary function tests are useful to map out the future. And then additional tests will be based on clinical features. So for instance, many patients will have sinusitis, so a CT scan of the sinuses may be helpful in some patients. Okay, so just moving on to the current treatments. So the main pillars of treatment, as you know, are broad spectrum antibiotics and physiotherapy to clear the sputum. And the idea is to break this this vicious cycle of inflammation, bacterial colonization, that should be chronic infection, and tissue damage. Preventing infections with influenza pneumococcal vaccination, and pulmonary rehabilitation is recommended. So at the moment, unfortunately, there's still very limited data on treatment. This is a summary of all the treatments. So the ones in green, there's reasonably good evidence for treatment. There's limited evidence for the nebulized antibiotics, and then there's really poor evidence for everything else. And nebulized DNAs, which is effective in cystic fibrosis, is harmful in non-CF bronchiectasis. So what's used in cystic fibrosis isn't necessarily translatable to non-cystic fibrosis bronchiectasis. So how should we treat exacerbations? Well, first of all, we need to define what an exacerbation is. At present, we don't have a clear definition, except this is a consensus definition which hasn't been tested formally in research studies. But the consensus of a group of experts is that there's a deterioration in 3 or more key symptoms for at least 48 hours. So it's got to be sustained. They can have 3 of these 6 symptoms, predominantly cough, sputum, breathlessness, fatigue and malaise, and hemoptysis. And the current treatment for bronchiectasis, as opposed to bronchitis or exacerbation of COPD, is a 14-day course of antibiotics, so a longer course of antibiotics. And these will typically be broad-spectrum antibiotics, often augmentin, because it also has anaerobic cover, roxithromycin, doxycycline, and clindamycin can be used in those who you're really having trouble with. It's a good drug in bronchiectasis. Macrolides are effective. They're one of the few drugs that have reasonably good evidence for use. Azithromycin, which is not funded, erythromycin, and have been trialled, but roxithromycin hasn't been trialled in large studies, but in a small study it has been shown to be effective. So overall, the macrolides do reduce exacerbation significantly by 40 to 60%. It's a substantial effect on reduction in exacerbation frequency. This is the most important, one of the most important endpoints for patients. Those who have exacerbations tend to do worse, they have a worse prognosis, they have a higher mortality. So reducing exacerbation is important. Like most things in bronchiectasis, lung function is a poor marker of it's a poor marker of effect. So there are only modest effects on lung function, even though it's very effective for exacerbations. There is improvement in quality of life from macrolide use, and we're talking about use of macrolides between 3 months and 12 months. But there are concerns about antimicrobial resistance, so we want to be very careful about those patients that we select to put on long-term antibiotics for 3 to 12 months or longer. And you want to consider them if they've got 3 or more exacerbations, but a lot of patients do have 3 or more exacerbations in a year, and so I tend to limit it to those patients who really are struggling, those who have poor quality of life as well. Okay, just going on to vaccination. So, as you know, many of you are vaccinating your patients. Annual vaccination efficacy in the community is about 60%, so it's not perfect, but it's 60% for any drug effect is a massive effect. So vaccination is a highly effective modality. What about hospitalised patients? They are less effective. This is data from the Auckland region and the Shivers project. They are less effective, 40%, but it's still well worth vaccinating patients because 40% efficacy is still excellent. Okay, so what about the pneumococcal vaccination? So pneumococcal vaccination has been known to prevent invasive pneumococcal infections such as meningitis. So very effective, we know for that. But for pneumonia, this is the first trial, the Capita trial, which has shown that it's efficacious in preventing pneumonia. And this is for the conjugate 13-valent vaccine, Prevnar. So 45% efficacy for pneumonia and 75% for invasive disease. So this is a recommendation, the Rolls Royce if you want to recommend treatment for your patients for pneumococcal vaccination, although it's not funded, unfortunately. But it is recommended, and the American guidelines also recommend it for chronic respiratory disease. So if they're naive, they've never had pneumococcal vaccination, ideally you'd give them the 13-valent conjugate vaccine first, then the 23-valent vaccine, and then if they've had the previous 23-valent vaccine, then you give them the 13-valent one a year later. That's the Rolls Royce, but there is a cost associated with giving both of those. Okay, so just a summary: increasing burden of disease, particularly Pacific and Maori population, and those are the treatments.